All right. Now, hello everyone, and thank you so much for being here with us today. To hear today's presentation in Spanish, please go to the Interpretation tab on your Zoom panel and click Spanish. You can also mute the English speaker's voice, clicking Mute Original Audio. Now we will review real quick a few housekeeping items. Today's event is being recorded and will be made available publicly through our website and other media channels. For today's webinar, all participants will be muted. Please make sure your computer speakers are turned on and up to hear today's presentation. If you're having technical issues, please send a message to the Hispanic and Latino Behavioral Health COE on the chat box. If you have a question for our presenters, we ask you to use the questions and answer tab on the tool. You can also raise your hand or send the question through the chat box. We will be sharing a copy of today's presentation in PDF format through the chat box too. We will also make a copy of today's presentation available to be downloaded through our website. You can also find it under the name of today's event. Please complete the evaluation. We're going to be sharing one evaluation at the very end, and this one is for the Hispanic and Latino COE. This evaluation helps us know more about your opinion and talks about the presentation and what other topics and training would you like to see offered. Our mission is to advance and support the sustainability and behavioral health equity by promoting community-driven, culturally grounded, and person-centered prevention, intervention, multiple pathways of recovery and recovery supports for diverse Hispanic and Latino community. And we strive to accomplish this mission through the development and dissemination of culturally informed evidence-based behavioral health information, providing training and technical assistance, and supporting the growth and expansion of the behavioral health workforce that serves the Latino community. Today we are co-hosting this webinar with the addiction professionals of North Carolina. Thank you so much for this opportunity. And I will be passing it to Samantha so she can share a few things before we begin the presentation.
Thank you so much. So I just have a few quick things. I won't delay us too much. We also have a survey just to get your feedback on the presentation today and would like moving forward. We also want to let you know that your certificate of completion will be available within 24 to 72 hours. Other than that, I will let Dr. Hernandez go from here.
Right. Good morning, good people, and thank you for joining us today. There's almost 100 people on. I'm going to begin with introducing myself. Whenever I go to training, I want to know a little bit more about the trainer. So I share with you some thoughts in that light. Again, my name is Hernández. I am from Puerto Rico. I live in Massachusetts. I have worked in the field of health and human services with a specific focus on mental health and substance use disorders, working on issues of disparities and equity for the last 37 years and a couple of months. I worked in inpatient settings, outpatient settings, and my work is, for the most part, in not-for-profit settings. I am director of public health at a local community-based organization here in Massachusetts called the New York Citizens Council, and we have a number of services that engage all communities, but we are in the heart of the Latino community here. In addition to that, I'm a national consultant on a number of programs that are funded by the federal government, so HRSA, CDC, and the Substance Abuse and Mental Health Services Administration. I have, as you saw from the title slide, I have more letters after my name than letters in my name. I am certified as a prevention specialist, certified and licensed as an addictions counselor, and I have a PhD. I also have a GED. And my GED I earned in prison, and it was more difficult to earn a GED in prison than a PhD out here. I am a person in long-term recovery, which for me means that I haven't used a drug, including alcohol, for 38 years and 1 month. That enables me to be a productive member of my familia, my community, to be here present with you today, and to engage in identifying resources and improving skill sets that are necessary to serve our populations. Thank you for the folks who are putting stuff in the chat. I am going to say a couple of more things about expectations for today. My style is not just to talk at people. I like to have a conversation with people. Given the fact that all cameras are off, that's challenging to do because we're not seeing folks. But the chat is open, so I'm going to encourage you to use the chat. I will have some questions for you, and I'm going to encourage you to raise your virtual hand. I will call on you once I see that, and then you can chime in on the presentation. Because we only have an hour and a half, I'm going to ask you that when you chime in, you put on your mic, that you be concise and to the point. I'll try to do the same from my end. Welcome everybody who's in the chat, introducing them as where they're joining from. So we are excited that you are here. In terms of the learning objectives, hopefully by the end of this presentation, you'll be able to describe principles of recovery and how they align with the cultural values of Hispanic, Latino, Latina populations. That you'll be able to discuss possible recovery management approaches when working with Latino, Latina populations. Describe the multiple pathways of recovery and wellness, and address the significant disparities in behavioral health outcomes, including opioid overdose rates in communities of color, and within recovery management strategies moving forward. So beginning with the fact that we need to ground the conversation in data, what's happening, not just across the country, but in North Carolina more specifically. We know that the Hispanic, Latino, Latina population in North Carolina is growing rapidly, 40%, as a matter of fact, from 2010 to 2020. So that's a decade. That's a huge jump in just 10 years. This is according to the U.S. Census. In 2020, the Hispanic, Latino, Latina population in North Carolina reached 1.1 million people, 11% of the total population. And 61% of Hispanic, Latino, Latina people in North Carolina are U.S. born. So contrary to what you might be hearing about immigration, all these people are coming here. The majority of people are born in the U.S., right? And so we need to understand that as well. So these are changing demographics. We have 5 years since the U.S. Census in 2020. And so there's more information there. In terms of substance use, the Department of Public Health in North Carolina today announced that there's an average of 9 folks from North Carolina died as a result of an opioid drug overdose in 2020. And that's a 40% increase from the previous year. Right, so that's a huge increase, 40%. There's increased alcohol use that has been reported by the Hispanic, Latino, Latina farm workers in North Carolina. There's a significant portion of the Latino population that are farm workers. And then disparities in access to substance use services exist for Latinos in rural areas where an increased amount of our folks live. Right, so when we think about geographical location, we know that there are the metropolitan areas, the suburban areas, and then we have the rural areas, and so there's disparities to be understood at all different levels. In 2020, the U.S. Census reported a 49.9%. That 49% of almost 50% of Hispanics had private insurance coverage as compared to 73.9% for non-Hispanic whites. This is of the entire country. So it means that there's a disparity there that we are already seeing in terms of who has access to healthcare and who doesn't. And that further complicates things for people on the ground. More than half of Hispanic adults age 18 or 90, 18 or older have mental illness, right? And these are youth between the ages of 12 to 17 with serious mental health disorder, did not receive treatment within the past year. Latino adults sought help for substance use disorder. More than 90% do not receive treatment. So that, again, a huge disparity. 90% of people needing substance use treatment did not receive it, which means that this highlights the disparities that we're talking about. And of the 2.4 million Hispanic or Latino who experienced both a mental and substance use disorder in the past year, only 25.4% receive any mental help, and only 10% receive both mental health and substance use disorder. These are co-occurring issues for people, right? So again, huge disparities in terms of who's experiencing mental health, substance use, and then co-occurring issues, who has access to care on both sides, and who has access to care when experiencing a co-occurring issue. So I'm going to ask you to put some stuff in the chat. I'm going to come to look at the chat since a lot of people have been putting some stuff in there. And I just noticed that there's not just people from North Carolina, there's people from New York, there's people from other parts of the country as well. So welcome. So how would you describe, in a word or two, how would you describe or have others defined recovery? What would you say to that? Any step towards wellness as the person seeking recovery defines. People from New York, from Puerto Rico chiming in. Any positive change as defined by the person. Continued process of change. Look different for everyone. It looks different for everyone. Having a community, ongoing physical, emotional. Is that? I missed the rest of it. It's nonlinear. It involves stages of change. We have folks from Oklahoma also chiming in. So all of these things are true and extremely important. Thank you for putting those in the chat, and thank you for your participation. I'm going to share with you definitions to, again, ground the conversation in solutions, right? In solutions. So in terms of those definitions of recovery, let's begin with the SAMHSA, the Substance Abuse and Mental Health Services Administration. They define it as a process of change through which individuals improve their health, wellness, live a self-directed life, and strive to reach their full potential. So this is the definition. Notice right off the rip, right? Notice mental health. They don't mention any of that. This definition doesn't. And by the way, this is a definition utilized by SAMHSA, but the way that this definition came to be is that a number of us, myself included, were brought together by SAMHSA from people from across the country, and we helped put together these definitions, right? There's some guiding principles here: hope and belief. This is extremely important for us to understand. I'm going to come to this in a moment or two. The 4 dimensions of recovery. And notice we're not defining addiction, right? We're not defining substance use disorders. We're defining the solution, because we want to live in the solution. So the 4 dimensions that are included in the SAMHSA definition are health, so living in a physically and emotionally healthy way, as well as overcoming or managing one's diseases or symptoms. And so health, again, is not in a one-dimensional way, right? It's multifaceted. So when we think about health, obviously it's physical and emotional health, but it's also financial health. It's also spiritual health. It's also many other things that are connected to health. So when we think about health, we need to think about it in a broader way when we're working with folks. The next dimension is home. So what are we talking about here? We're talking about a safe and recovery-conducive place to live. So think about it. I'm hoping that all 143 of us that are on this webinar have a healthy and safe place to live, right? And we know what that means, that when I arrive home, I can go like, I'm home, this is my sanctuary, I feel safe, right? Think about that as it relates to issues of recovery for people. If they're living in situations or in housing where it's not that safe, where it's not recovery conducive, where people are still using. Now, there are people who live in those conditions and are still identify themselves as being in recovery, and that's fine. But we want to make sure that we encourage and promote this structural determinant called place to live that is healthy and recovery conducive. The next domain is purpose. And so these are meaningful daily activities, such as having a job, being in school, volunteering, taking care of family, creative endeavors, and one always has to consider the independence, income, and resources to participate in society, because this does come with some level of cost. If you work with people who identify themselves as being in recovery, you might have heard some people say, as soon as they're in recovery, a month, 2 months into it, a little bit into it, most people will start saying, I want to give back. I want to give back. I want to give back. That is people mentioning purpose without saying the word purpose, because giving back is a form of creating purpose in one's life, right? Whether that's through working, whether that's through volunteering, whether that's through whatever lens of service that people bring, that's what people are talking about. And that's why this domain is extremely important. And for us, it's important as well, right? Everybody has purpose in life, right? There's a reason why we get up in the morning. It's no different for people who identify as being in wellness or recovery processes. And then community relationships and social networks that provide support, friendship, love, and hope. Now, when I was actively using substances, I belonged to certain communities. I belonged to the community that was incarcerated. I belonged to a community that was using substances. I belonged to a community that was engaged in illegal activities. I also belonged to my own community in Puerto Rico, and I belonged to that community. Right? As soon as I entered recovery, I had to learn about this concept and the different aspects of community, and then I had to build community around me and become engaged with other communities. So today, I'm a part of the professional community. I'm a part of the recovery community. I'm a part of a men's community that does very specific work in the realm of men seeking and needing recovery. So I belong to many different communities, but that didn't happen. It didn't fall from the sky, and it just didn't happen by coincidence. It happened because of purpose. It happens because of connection, right? And so we need to make sure that we are engaging people in those processes. The final slide here, as it relates to SAMHSA and recovery, is again back to the working definition. It is person-driven. It involves many pathways. It is holistic. It includes peer supports. It is relational. It involves issues of culture all the way around. It addresses trauma. It leads with strengths and responsibility. It includes respect and hope, right? So those concepts become extremely important. To that slide earlier that I said I would come back, if we are looking for broken people, that's what we're going to find. But I prefer to look at people as not broken, as people with resiliency, with strengths, with the ability to get better. And I believe in people maybe more than what they believe in themselves. That's the gift that was given to me. When I went from prison to treatment, I didn't believe I could get better. I didn't even believe that I had a problem. My problem was that I got arrested. When I arrived there, I encountered people who believed in me more than what I believed in myself. And that gift is a huge gift that we can give people. It doesn't cost us anything. But if we begin with looking at people as broken, then that's a deficiency model that we should move away from. Okay. Allow me for 2 seconds to just look at the chat and what's going on there to see if there's anything pressing. I'm trying to do multiple things at the same time, and then there's a couple of things in the Q&A. I'll come to the questions in the Q&A a little bit later. Let me move forward with presentation. Here's another definition of recovery. This time, I bring you William White. If you haven't heard of William White, I encourage you to go to Google William White papers, and it'll bring you to his research. William White is the leading research in all things recovery in the country. He is also a person in long-term recovery. There's a whole bunch of videos, and all of his work is available free of charge to us. And all of his work has been published, and their books and everything else. So he defines recovery as the experience of a meaningful, productive life within the limits imposed by the risks of addiction. Recovery is both acceptance and transcendence of limitation. It is the achievement of optimal health, the process of rising above and becoming more than an illness. Recovery, in contrast to treatment, is both done and defined by the person in recovery. This is a mouthful, and it's different from the SAMHSA definition. And he is specifically talking about addiction, and he mentions addiction here, right? So he talks about a productive life, but he acknowledges that there are limitations because of the risks of addiction, right? He also says that recovery is both acceptance and transcendence of limitation, which is extremely important. You know, when people go around telling folks, oh, you can be whatever you want to be, it is aspirational, but that is not actually true. I have a criminal offender record that goes back many, many years. There's limitations there in terms of what I can do and what I can't do, right? Now, some of the limitations I need to understand, accept, and explore. And then some limitations I have been able to transcend. And this is what William White is talking about, right? To be realistic in terms of that, right? He talks about optimal health. And optimal health is relative to the person, right? What is optimal to me might be different and for someone else, right? This next sentence is extremely important. The process of rising above and becoming more than an illness. Why is William White talking about this? I know William White personally. I've read his stuff and I've had many conversations with him, and I've had the pleasure of being in the audience when he's presenting. That what he's talking about here is that our field, both mental health and substance use, we have pathologized people. We have treated people badly. We go around calling people addicts and frequent flyers and schizophrenics and bipolar and in denial, and all of that doesn't serve anybody good. And so I am not an addict. I introduced myself this morning to you as my name is Hernández, and I'm a person in long-term recovery. What that means for me is that I haven't used a drug. Right? I gave you all of that information. Why? Because I don't want anyone to use my experience to further stigmatize and pathologize our people. And this is what William White is talking about within a very concise sentence, right? But I figured it's important to break it down. To some of you in your definition of recovery in the chat, I'm going to come to that because you were extremely on point, has to do with the final sentence here. Many of you very specifically said what the person wants, what the person is willing to do, how they define it, that sort of thing. So recovery in contrast to treatment. Why in contrast to treatment? Because treatment has been defined by us, recovery professionals, with a lot of initials after our name. We do treatment on people. And some of us would say we do treatment with people, but it's still defined by us. He says, in contrast to treatment, recovery is both done and defined by the person in recovery. So when I meet people and I ask people, so how do you define recovery or wellness for yourself? Whatever they tell me is whatever I accept. That's what I accept. I don't go around saying, well, that's not it. Because what we have done as well is that for some people who are on medication-assisted treatment, we say, oh, that's not recovery. Oh, you just switch from one drug to the next, or someone who stopped using this drug but is still using this other drug. We say, oh, that there's no progress there. It's problematic for us to impose our will and our way of thinking on other people that doesn't allow for people to have self-determination, agency, right, and choice. Because that's the other piece that we're talking about here. Okay, let me jump to the next slide here. And so we should be considering recovery as a person-centered, strength-based process. right? So we should be considering it in that way. What are some of the areas that clinicians should explore, given the fact that we should be considering it as person-centered and strength-based processes? If you can put some of that stuff in the chat, that would be helpful. Catherine, thank you for the piece that you put in the chat. I've been trained in the same way. People are in recovery when they say they are, right? It's not up to me to tell them when they're in recovery or not. The problem with this is that many people want to tell people if they're in recovery or not because they have their own definition. So Sarah, thank you for that. Recovery capital is things that folks should explore. How does this model address substance? Okay. Cultural religious supports, yes. Kimberly, let me see other stuff that has been put here before. All right. Any other things that you think clinicians should explore? And we can expand it out because there's family support. Thank you for that, Elizabeth, because it's not just clinicians in this room. I know some of the names that are being on the webinar. It's not just clinicians. So what other things should we explore when working with people if we're coming at this from a strength-based approach? The social determinants of health. Housing, food, healthcare, employment, somatic tools, body regulation. It takes a lot for someone to want and commit to recovery. I believe all interactions should be started with commending them. Yes, that's a strength-based approach. I believe that you can do this. I am your cheerleader. I believe that there are things that you have already done, even if you haven't stopped using, that brings you into the fold, right? How does this model address the social determinants of health? The better question is, how do we address the social determinants of health? And we should be thinking not just about the social determinants of health. We should be thinking about the structural determinants of health. Structural implies the built environment, right? And it is important for us to address the built environments, right? That's housing, that's education, that's healthcare, that is community conditions, that is all of that, right? That is institutionalized racism. Those are structural determinants of health that have been baked into the cake. Catherine, thank you for this. Harm reduction. What is their desired outcome and how can I help them to achieve that? Empathy and genuine care. I'm going to move on, but those are really good additions to what we're talking about. Thank you for keeping the chat really busy. One of you mentioned recovery capital. And so William White and others have done a lot of work in the area of recovery capital, which is the breadth and depth of internal and external resources that can be drawn upon to initiate and sustain recovery from substance use disorders. This can also be extended to what? To mental health issues as well, right? Recovery capital is internal and external. When we think about the external pieces, right, we're talking about the structural and social determinants of health, because we are talking about housing, we are talking about healthcare, we are talking about education, all of those things, right? The internal is my ability to advocate for myself, my ability to say yes, to say no, my ability to develop empathy, right? All of those things are internal, and we should be paying attention to, as providers, to both internal and external. Recovery capital is conceptually linked to natural recovery. Solution-focused therapy, strength-based case management, recovery management, resilience and protective factors, and the ideas of hardiness, wellness, and global health. There are several types of recovery capital that can be influenced by professionals. This is William White's work, again, coming back into the fold, right? And so we can influence internal recovery capital and external recovery capital. And you notice that William White mentions natural recovery here, right? We're going to come back a little bit later to this concept of the multiple pathways of recovery. There's some stuff happening in the chat. Let me go there. They should explore their own biases. Thank you, Sarah. Sarah's saying to us here, I should, Haned should explore my biases and judgments because we all have them. We all have them. And if we don't admit that we have them, they're going to come out. in what we do, right? I would like to connect the definitions, particularly in the recovery on the Hispanic side, and the cultural barriers that affect. We're going to come to the cultural elements a little bit later on, and welcome other folks who are just joining. So I'm trying to do my best to keep up with the chat. There's 152 people here. There's a lot of happening in the chat, but I want to also make sure that we cover as many things as possible. So in terms of families in recovery, now we're talking about Hispanic, Latino, Latina families, but this is applicable to other families as well. Some people don't view substance use or mental health disorders as a disease. They view it as a moral failing. This is a lack of education. So we see this as a deficiency, but it's also an opportunity to address this through family involvement in recovery processes, family involvement in treatment processes, right? There is distrust, and we should expect that from family members, and some will be looking for signs of old behaviors. I remember in very early recovery, I used to come and visit my family, and my mom and others would always be with a vigilant eye in terms of when I arrived, who I arrived with, what did I do, looking at my arms to see if there were any track marks at my neck, because I had track marks on my neck when I was injecting substances, right? All of those things. And me, as in early recovery, I saw that as you don't trust me and you don't support me. What my mentors, what my folks in my recovery process taught me is that that is a part of this process. You need to understand that what you left behind in your wake was a lot of destruction. And so you can't expect people to trust you from one day to the next, right? There might be over harsh communication about past behaviors and anguish and problems caused to the family can impact recovery processes, right? Again, the impact on family is extremely important. In the US, for the most part, our system of care, of treatment, involves what we call the identified patient. Listen to that language, right? Or the identified client. The reality is that mental health and substance use issues are a family issue. When you have a mental health condition and or a substance use issue, it impacts the entire family. And so we should be including family as much as possible. It may not be possible to engage the family or most significant members of the family in treatment if the family is not ready. But we can move in that direction of readiness if we continue to work with the family by way of education, those sorts of things. These are for people who have family present nearby, right? So some people don't have that benefit. Quite often, family members with substance disorders and mental health challenges will continue to reside in the household. Why do we say this? At some point in time, when I entered into my recovery process, someone said to me, "Oh, you can't hang out with people who use drugs, and you can't live in places where people use drugs." I come from a family there's several people who use drugs. What am I supposed to do? Cut ties with family members? For some of us, that's impossible. We refuse to do that. Right? That is impossible to do. Now, some people have been able to, right, create boundaries, and I have been able to create boundaries. But this whole idea of telling people you can't live in this household or you can't live in this community because there's drugs present. So where am I supposed to live? Where am I supposed to go? Right? So we need to be careful with the messaging around these issues around family. But family is always an important things to think about. How have you seen these processes in Latina families, in Latino, Hispanic, Latina families, if you are working with them? How have you seen these? If you can put some stuff into the chat, it's going to be helpful. Understanding that substance use is a family disease and only culturally humble. Thank you for that. Javon, if I'm mispronouncing your name, I apologize for that. Any folks with how you've seen this in Hispanic, Latino, Latina families? Probably more supportive. Kimberly, thank you for adding that. These processes are even more difficult to navigate in multi-generational, multicultural homes. Lisa Vasquez Castro, I agree with you 100%. Setting boundaries during family parties, yes, very much so, right? Expectations, setting boundaries, communication, education, all of those things are extremely important. I've seen these things play out in many different ways. There are folks with hands up here. I saw hands up or no? Israel Reyes Morales, raise your hand. If you're going to mute yourself and chime in, please be brief and to the point. Paola, can we get some support with Israel? In the meantime, while that's happening, oftentimes family sees it as a moral failing. That's in the slide, like the parent did not. Yeah, the whole moral failing piece, they see it here. Yes, I've also seen, the chat is moving quickly. Uh, uh, as though Hispanic culture doesn't talk much about what they're going through, or trust is there. I agree with you. Families were supportive with the process. I love your comment about people, places, and things, referring family members to support groups. All of those things are extremely important. Paola, are you able to unmute Israel?
Sir, I asked her to unmute. I enabled the little setting for her, but I have not seen a response.
All right. So I'm going to move us on in the interest of time. Thank you for all of that, right? So when we think about the advantage of the recovery management model for communities of color, and now we're talking about recovery in marginalized communities very specifically, right? There's a broadened perspective that considers historical trauma. Some of you have mentioned trauma in the chat, and it's important to have this historical trauma in mind. Many people say, oh, that happened a long time ago, you should get over it. Well, things, as it relates to trauma, things don't happen that way. Just get over it. It's not a strategy, a clinical strategy or otherwise, right? It's actually a judgment that comes from a lot of bias, as Sarah reminded us that we need to keep in check. A focus on building vibrant cultures of recovery, right? That connection, the community piece that we talked about earlier, a proactive, hope-based approach to recovery engagement. Again, being strength-based becomes extremely important. The inclusion of indigenous healers and institutions. Many people from Hispanic, Latino, Latina communities, they have other practices that are indigenous practices, that are grounded in spirituality and those sorts of things. And we need to acknowledge, we need to incorporate those things whenever possible, and an expanded menu of recovery support services. Again, it's not my way or the highway. We need to have an expanded menu. Culturally grounded Catholic metaphors and rituals, right? Again, back to the cultural pieces that people practice. It is important that we bring those out, that we understand them, and that we incorporate them. A culturally nuanced approach to research and evaluation. So what does research and evaluation look like when it is informed by the culture and the cultural elements present within these communities, right? In terms of marginalized communities, it moves beyond the clinical skills of assessment, diagnosis, and of individuals, and encompasses the skills of family reconstruction, community resource development, and nation. You see that this model very nicely incorporates and has within it all of the stuff that you were talking about in the chat as it relates to family and community, right? And resource development, and this piece on the structural determinants of health that folks mentioned on more than one occasion, and its connection to nation, right? Nation in many different ways. It's premised on the belief that the community experience through group solidarity with a historical and geographical community. And this is an essential dimension of personal healing, right? So this solidarity, right, geographical and historical, comes to mind. Again, when people say, oh, we're not dealing with that here, that is not important, you should get over that. Now you live in the US and that here is not relevant. All of those things are punitive, they're not strength-based, and they actually do not help recovery processes. When we claim to want to do better, it's important for us to then incorporate these things into our approach, whether that's a clinical approach, a recovery support services approach, a prevention approach, whatever your role is. And I included other roles and not just the clinical people, because I know that there's non-clinical people in the room as well. Now, I refuse to go anywhere in the country and talk about substance use and mental health issues as it relates to any population. But here we're talking about the Hispanic, Latino, Latin population without addressing the elephant in the room. And the elephant in the room is mass incarceration, right? In 1970, there were 200,000 people incarcerated in the US. We fast forward to today, that's 2.3 million people. That's the largest prison population per capita in the world. The US does really well in incarcerating people, right? The largest prison population per capita in the world, right? If we add the 5 to 6 million people who are on probation, parole, house arrest, that's almost 10 million people. I'm going to give you some additional data. Every year from county jails, we release 7 million people, approximately, from county jails alone. From state and federal prisons, we release almost 600,000 every year. If you combine those two numbers, that's almost 8 million people that we release every year. Of those almost 8 million people, 75% of them will be rearrested within a year, and 50% of those are going to do time again. The majority of those folk who are coming out of prisons and jails have a substance use issue, over 80%. Over 65% have a mental health issue, and a significant number have a co-occurring issue. Most have physical health issues. Many experience homelessness. Most, if not all, have experienced trauma from the very incarceration, from the very conditions on the ground. This is the reality for many people who have substance use and mental health issues. Yet our system forces people into prisons and jails in order to maybe have access to treatment and care. Get this figure. The largest provider of mental health services in the country are prisons and jails. I'm going to repeat that. The largest provider of mental health services in the country are prisons and jails. I don't know about you, but if you have a mental health issue, if I have a mental health issue, the last place where I want to go get it treated is at a prison or a jail. There are really good people who are working behind the walls, doing really good work and providing services. But that is not the place to provide people, the majority of people, mental health services in the country. It should be in the community, right? Now, I'm not Pollyanna. I did some things in my day that I deserved to go to jail. Some of the stuff that I did was right. But the reality is that what has kept me out of prison was access to recovery, access to the recovery community, access to resources, access to people like you who humanized me, who treated me with decency and respect, who educated me about this whole process, right? This is a huge thing that we should not ignore. Now, policies that have driven mass incarceration in the country, right? So I'm going to ask you in the chat, what policies do you think have driven mass incarceration? If we go from 200,000 people in 1970 to 2.3 million people in present day, what policies do you think have driven mass incarceration? Lisa, thank you for that. The war on drugs, 1970. Any other policies? 3 strikes and you're out. Other policies, 3-strike rule, yeah. Other policies, minimum sentencing, stop and frisk, yeah. In the interest of time, I'm going to move us forward here, right, and give you the policies that have been implemented in the US. So the institutionalization, this is 1960, right? This is closing of all state mental institutions, they were called at the time. There was 2 parts to that law. Let's close all the state mental institutions at the state level, and then let's reintegrate people back into community. The first part happened, the second part did not, right? So the institutionalization, 1960. The war on drugs, it was mentioned here, right? 1970, Richard Nixon was president at the time. We're going to go after people who use drugs, who possess drugs. We're going to begin to intervene with countries who produce drugs as well. The criminalization of behaviors for the folks who are talking about profiling, for the folks who are talking about stop and frisk, all this grows out of the Rockefeller laws in New York State, right? There were things that at some point were not criminal activities, and now they are. Now, the U.S. Supreme Court did over the summer of this past year, 2024. They deemed that and this is the term that's used, not a term that I use, but they call them homeless encampments, that those things are illegal and they're breaking the law. In other words, they can be arrested and it's been criminalized. Right now, some folks are trying to criminalize panhandling, right? Imagine that. Who do those laws target? So the criminalization of behaviors, powder versus crack cocaine. This is 1994, not Richard Nixon, but Bill Clinton, the largest crime bill in U.S. history. The disparities in sentencing between powder and crack cocaine were 100 years to 1. Right? 100 years for crack cocaine to 1 year for powder cocaine. 100 years to 1. Obama brought it down to 18 years to 1. This devastated Black and brown communities of color, right? Where there are people doing 20, 30, 40 years for small amounts of crack cocaine, when folks who were caught with large amounts of powder cocaine, access to money, access to resources means lawyers got off with a different type of sentence, right? Mandatory minimums. When people here mention that 5, 10, 25 years behind the wall without the right to probation or parole or early release or supported release. Most people don't get reentry services, right? Voting rights. No one has mentioned this one that I could see in the chat. In upwards of 20 states, if you have a criminal offender record like the one that I have that includes felonies, you cannot vote, right? Now, mind you, people paid their debt to society. So why continue to punish people? Why continue to punish people? School zones. These were designed for inner cities. The majority of people who live in inner city are people of color. You get an additional 2 years attached to your sentence if you are arrested within the school zones. And school zones are schools, parks, and daycare centers. And that law operates 24 hours a day, even when those spaces and places are closed. 3 strikes and you're out. Folks mentioned this, including Kimberly in the chat. There's a guy in Texas right now doing life in prison. His 3rd strike was stealing 2 slices of pizza. There's a guy in California broke into a soup kitchen, life in prison. I have a friend here in Massachusetts, habitual criminal. His 3rd strike was stealing a car. I don't know about you, but no one should be in prison for life for those types of offenses. They should not. We criminalize hunger and poverty when we do these types of things. No one mentioned this, but massive prison construction as a policy. Go from 200,000 people incarcerated to 2.3 million overnight. You need to build prisons. And that comes with hundreds of billions of dollars in contracts, right? Which brings me to my next point, the privatization of prisons and jails and the services within them across the country. If you're sitting in this room and you have a 401k or 403b, which is a retirement account, that you do have one, you probably have money in private prisons and jails and you don't know it because they're traded on the New York Stock Exchange. You see, there is a profit motive here, just like there's a profit motive within healthcare in the US. Now think about that. Number of people that these systems employ, including some of us in this room, who have jobs because of mass incarceration, right? And then the nice bow on this entire thing are criminal offender records that follow people around for forever and ever. They make it more difficult for people to get their kids back if they were taken away from the system, to get housing, to get a job. These policies sustain stigma in very specific ways. The final piece of data that I want to give you in this section are so-called plea bargains. I don't know how many of you are familiar with so-called plea bargains, but 97% of all cases at the federal level are pled out. and 94% at the state level pled out, which means that the majority of people never see a jury. They never take things to trial. And that is because most people in the system are poor. And when you're poor, you are locked up. You get a public defender. That public defender has 150 to 200 people on their caseload. And if you've never experienced this, take it from those of us who have. You're sitting in the bullpen waiting to be sentenced. Your lawyer comes to the back and says, Sarah, this is your third strike. The DA out there is pissed and they want to give you 25 years to life. Are you willing to take 10? Kimberly, they want 10. Are you willing to take 5? Juan, they want 5. Are you willing to take 2? Lisa, they want 2. Are you willing to take 1? Hanel, they want 1. Are you willing to take probation? The majority of us are going to take that so-called plea bargain because we know what would happen if we don't. That friend of mine who's doing life in prison here in Massachusetts for stealing a car was offered 15 years for stealing a car. He didn't take the plea bargain. He took it to trial. And there you have it. Found guilty and hit with habitual law, lifetime in prison. That's the system that we have built, right? Now, here's a question. Here's a question for you, for all of you. How many of you think that this is a broken system? Raise your virtual hand, or make. How many of you think that this is a broken system? I want you to think about that question. Do you think that this system is broken? If you raised your hand and said it's broken, look at what's happening in the chat. It's not a broken system. It works exactly the way it was designed to work. Why? Because these are deliberate policies. These policies did not fall from the sky. They were thought out, they were voted in, and they produced the hundreds of billions of dollars in profit, including jobs for a lot of people who are involved in this process and a lot of corporations who are involved in this process. Marcus, thank you. Slavery by Another Name. I'm going to recommend that people watch The 13th, which is a documentary about the 13th Amendment on Netflix. Really, really good about the issue of slavery and mass incarceration. Thank you for all of those comments in the chat. Very profitable, all of that stuff that's happening there. Let me show you some data here about the number of young males between the ages of 25 and 29 per 100,000 who are incarcerated in the US. This is the disparities piece here, right? If you look at whites, per 100,000 is 1,437. If you look at the Hispanic, Latino, Latin population for young males, it's 3,892. And then look at what it does for Black young men in the country, 8,932. If these don't scream out disparities, I don't know what does. The reality is that people have said, oh, Black and Latino young males are more prone to criminal activity than their white counterparts. And this is why this data looks this way. That is a racist statement. Nothing could be further from the truth. As a matter of fact, whites commit more crimes than their Black and brown counterparts, but they're sentenced in a very different way. And if you're looking at this and you're saying, well, that number for whites is low, 1,437, never forget that, yes, that number is lower than the other two numbers, but these are white poor males who get to experience that system as well, right? The one thing that they don't experience is racism within that system. But being locked up in that system and the trauma that comes with it, they experience that too. Now, how many of you believe that we have an opioid crisis in the country? Right? How many of you believe that we have an opioid crisis in the country? Huge epidemic, Ernesto says. I believe it, huge. Other people are saying that. All right, cool. Huge. People are saying that now. So here's the question. After decades and decades of people dying, because we've been dying for decades, over 1 million people have died since 1999 to present, why declare a crisis in recent history? Why do you think a crisis declared in recent history? Because people have been dying for decades and decades and decades. Yep, Amanda, you got it. First person to say it. White folks began to die at alarming rates. And before anybody gets upset at that statement, which is a reality, right? Whites deserve prevention, intervention, the multiple pathways of recovery and recovery supports. And so does everybody else, you see? So does everybody else. So while some of you, or the majority of you said, yes, we have this opioid epidemic, I disagree with you. Respectfully, I disagree with you if you think that we have an opioid crisis. Why? Because our crisis is way more complicated than just opioids. We have a crisis in substance use disorders, plural, not singular. You see? More people died last year of alcohol-related disease than all the other drugs combined. Why are we not talking about alcohol? People die of methamphetamine use. People die of cocaine use. People die of pill use. People die, yes, of opioid use, but it's more complicated than just opioids. We have a crisis in over-criminalizing people. We have a crisis in healthcare. We have a crisis in employment opportunities. We have a crisis in affordable housing. We have a crisis in mental health. We have a crisis in education. And this all turns out to be a crisis at the community level. When we are myopic about what the problem is, and we repeat what we've been told by the powers that be, we collude in those processes. And here's why I am asking you to rethink that. Right? And I'm going to give you an example of public health here in Massachusetts. In 2017, there was an 8.3 reduction in opioid overdoses in Massachusetts. You know what happened in 2023 in Massachusetts? 10% decrease in opioid overdoses in Massachusetts, right? In 2018, 2019, there were 4% reductions in opioid overdoses in Massachusetts. Again, in 2023 in the US, there was a 10% reduction in opioid overdoses in the country, right? And so what did people do? They started to clap. They started to applaud and say, yes, we're doing great. We're reducing, and then the celebrations began. I am one of those people who doesn't celebrate that. And I call upon all of us here not to celebrate that. Why? Why? Because between 2015 and 2017, opioid overdose increased for African Americans by 83%. By 83%. Evelyn Delgado in the chat, reductions affected predominantly white folks. Exactly. Between 2015 and 2017, opioid overdose deaths in Massachusetts increased by 100% for the Latino population. So the question is getting better for whom and why? Here's the answer to that. Because resources were put heavily into white communities, and our communities were left out of those processes. And so, of course, you thought that there's an opioid crisis, you put money into those communities. But our communities are not just dealing with opioids. They're dealing with housing, with education, with incarceration, with all of those things. We didn't get the benefit of that, and it gets to be worse. So we need to have critical thinking about these things and not fall in line and believe that these things are just magically going to go away. They're not. There needs to be strategies, and our communities are under attack as we speak. So what has this, and thank you for all the comments in the chat, right? What has this left us with? It has left us with dehumanization, right? We, if someone says a dog was hurt, people will jump at the opportunity to help a dog. While going to help the dog, they'll step over someone experiencing homelessness, right? We have been stigmatized, which is a fancy word for discrimination. We label people, we dehumanize people, then we yell at people and say, oh, you need to pull yourself up by your bootstraps. Really? Really? No one can do things for themselves and on their own. No one has ever done that. We are interdependent. If you have boots, and those boots have bootstraps, try to pull yourself up by the bootstraps, right? Try to do that. This whole emphasis on personal responsibility. Oh, you just need to get over it and take personal responsibility. There are 23 million people in the US who identify as being in recovery. 23 million of us, bar none, have taken personal responsibility. 44 million identify as being in recovery from mental health issues. 44 million of us have taken personal responsibility. The question is, when do systems take on responsibility for creating the structural determinants of health that prohibit people from getting better, that make it more difficult for people to get access to healthcare, to substance use, to mental health, to all those services that people deserve and demand. And by the way, people are asking about the slides that we made available in PDF form. So yes. So moving towards this strength-based approach and strategies and solutions, right? We've already been talking about those. It's 11 o'clock. I want to make sure that I get through these slides. So I'm going to move through some of this stuff rather quickly, and then to the Q&A, because there's some stuff there that we need to get at, hopefully. So one of the first things that we need to understand is not everybody is at the same stage of readiness to change. So there's something called stages of change given to us by Prochaska and Di Clemente, who thought a great deal about how humans change behavior, right? And so there's such a thing as pre-contemplation. Those are the folks who say, I'm not ready to stop, I'm not interested in stopping. And there's a group of those folks who don't even know that they have a problem. And so we go around calling people in denial. And so that is a punitive approach to this stuff and not really understanding what's happening with people, because all of us, myself included, are in denial about something. As a matter of fact, denial is a safe self-defense mechanism that in some instances keeps us healthy, right? So be very careful with just pointing fingers. We are here to better understand, not to blame people. But there's people within that group. And then there's people in contemplation. These are people who are thinking about it, not have made a commitment, but are thinking about making whatever change that is. And then there's some people in preparation. Obviously, they're preparing for that change, right? There's some people in action. These are folks 3 to 6 months performing that action, according to Prochaska and Di Clemente. And there's some people who are in maintenance. These are folks that have been doing whatever that behavior change is, stopping something or starting something, and have more than 6 months of doing that. They're in maintenance. The challenge with our system is that we believe that everyone who's in front of us is in action or preparation or maintenance. The reality is that many people have been coerced by family, by courts, by probation, by conditions on the ground, and they end up in front of us, and they're in pre-contemplation and contemplation, and here we are treating them as if they were in preparation, action, or in maintenance. We need to better understand what stage of change people are in and then go from there. We need to be about strengths. Again, if we're looking for broken people, that's what we're going to find. If we're looking for broken people, that's what we're going to find. I refuse to do that, right? Because people who have spent 5, 10, 15, 20, 25 years on the street, or 5, 10, 15, 20 years in prison, they survived that ordeal. They survived through that trauma. They have strengths. They made it through. Some of us wouldn't last one day. So I refuse to look at people as broken. I am charged with looking at what's possible, at building people up, at saying to people, I believe in you more than what I believe in, more than what you may believe in yourself. And then supporting that with actions that support recovery and wellness, right? So we should move away from this strength-based, from this weakness-based deal of pointing fingers at people, because that has not helped anybody. Think about whenever you want to change something in your own life, who were the key people who supported you? You can remember them. You know why? Because they supported you, and you know how they made you feel. And you also know the people who have not been supportive. And those people, hopefully you ran away from, because you said, I'm not getting anything out of this. So the question is, we as providers, as helpers, how do we want to be seen? How do we want to be experienced, right? By the people that we're trying to help. But there's still a lot of punitive approaches within our field that we need to get rid of, including language that's problematic. Right now, we need to follow the money, because there's a lot of money coming into our field. I have 3 buckets for you. One is within community healthcare settings, including hospitals, federally qualified health centers. There's a lot of money coming there. There's a lot of money that's coming to criminal justice settings. So your probation departments, your courts, your jails, your prisons, your sheriff departments, your police departments. There's a lot of money coming there. And then there's money coming into community-based organizations like the one that I represent and many of you represent that are here. Now, here's your question. Who do you think is getting most of the money? Who do you think is getting most of the money? Okay? I'm going to give you the answer. Emergency, healthcare settings, criminal justice settings. Now, these are the folks who gave us overprescribing of opioids, have contributed to discrimination, have contributed to mass incarceration, have contributed to all of this stuff. So this is an equity question. Why do the folks who have contributed most to the problem are getting most of the dollars? Community-based organizations, including faith-based organizations, Karen, are not receiving the fair share of the dollars. Now, who do you think has most of the community's trust? It is community-based settings. It is community-based settings because of the history of being there, because of who they hire, because of their approach, right? All of those things. So that is an equity question around resource distribution. I'm not saying that criminal justice settings and healthcare settings don't deserve to get monies. I'm saying is that we should be more equitable in how those monies are distributed. Yes, Maria, nonprofit organizations get grants, but they don't get the majority of the grants. Is what we're talking about here, right? Now, we have moved to a single focus solution. You remember what the single focus solution was for decades and still is in some circles? That single focus solution was abstinence for everybody. So everybody needed abstinence. It was the gold standards was abstinence. Amanda was driven by that crap of just say no, you're right, okay? As you're putting that into the chat. But it was abstinence for everybody. So what did that mean for people who were using medication? What did that mean for people who were using other pathways of recovery? It meant that they were stigmatized, that they were marginalized, that they were treated badly. What is that single focus solution that we have now? The single focus solution that we have now. It is medication-assisted treatment. Now, do I believe in medication-assisted treatment or medication-assisted recovery? Of course I do. Of course I do. But I do know this, and the research shows this, and evidence shows this, that there are multiple pathways of recovery. There are many ways of getting better, right? There are many ways of getting better. So I'm going to invite you to do something for us in the chat. Name a pathway of recovery. Name a pathway of recovery. You don't need to describe it, but just name it in the chat. Let's do that exercise. 12-step, does it work? Of course it works. Is it for everybody? No. Dharma recovery, does it work? Of course does it work. Is it for everybody? No. I'm going to skip over some, and I'm going to do that purposefully. Holistic approaches, your yoga, your meditation, your acupuncture, do those work? Of course they work. Are they for everybody? No. CBT, does it work? Yes. Is it for everybody? No. Spiritual approaches or faith-based approaches, do those work? Are they for everybody? No. Abstinence-based approaches, do they work? Of course they work. Are they for everybody? Right? Native American approaches with, sobriety, does that work? Of course it works. Is it for everybody? No. Smart recovery, rational recovery, celebrate recovery, do those work? Of course they work. Are they for everybody? No, they are not. Right? People are putting drug courts. Drug court in and of itself is just a drug court. That pathway is something different. Are people going to 12-step? Are they doing Dharma? Are they doing faith-based? Are they doing 12-step, whatever it is that they do? Those are the pathways. The drug court in and of itself, just like a prison, is not a pathway of recovery. It can be a pathway to recovery, and that's different, right? NA, Narcotics Anonymous, faith-based, people put prayer, I put that. Do those work? Of course they are there for everybody. Therapy, that is formal treatment, inpatient, outpatient. Do those work? Of course they work. Are they for everybody? No. Community-based programs, right? Education, support groups, all of those things, do those work? Are they for everybody? No. Now let me pick on one that you notice that many people put into the chat, but I skipped them. right? And that is harm reduction. Now, I'm going to ask the same question that I asked. Does harm reduction work? Answer yes or no in the chat. Nothing else. I'm not asking you to put anything else. Does harm reduction work? Yes, 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 yes. People are putting yes, yes, yes. Okay, we got that. Now stop, 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 stop. Now, is harm reduction for everybody? Answer that. Is harm reduction for everybody? No, 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 no. Okay, and one yes. Okay, couple of yeses. Okay, we got some disagreement here. So let me stop you there and let me say this. My view is that harm reduction works, and it works for everybody. Now, let me give you some data here, right? I woke up this morning, I brushed my teeth. I look both ways before I cross the street. I put on my seatbelt, right? I don't hang out with people who use drugs. I don't hang out in places where drugs are being sold unless I am working. So I practice harm reduction on a daily basis, and so do you. But harm reduction gets controversial in two areas, sex and drugs. And these days it's more controversial in drugs than sex. So what's the most controversial thing right now of harm reduction? Answer that in the chat. What's the most controversial thing in harm reduction? Centers. What type of centers, Ernesto? Giving people needles. Needle exchange, OPCs. These are opioid prevention sites, overdose prevention sites, needle distribution, blah, blah. So let me give it to you because some people already put it in the chat. First, let me just acknowledge this. You've all acknowledged that most of you thought that harm reduction isn't for everybody. Well, harm reduction is for everybody. Harm reduction has been around for millennia, and we've all used harm reduction. You stop at a red light, right? That's harm reduction. You stop at a stop sign, I hope. That's harm reduction. You brush your teeth, you take a shower, you put on a coat because it's cold, you turn on the AC because it's hot. That's harm reduction. Everybody uses harm reduction. So it gets controversial in drugs and sex. More drugs and sex. So what is the most controversial thing right now? The most controversial thing in the country are opioid overdose prevention sites, which at some point were called needle exchange, at some point were called syringe access places, those sorts of things, right? The most controversial of them right now is what some people call safe consumption sites. There are a few in the country that are legal and that are operating. Now, let me ask you this question. Say yes, only respond yes, if you've ever been into a safe consumption site, into a place where it's legal to consume substances. Answer yes or no. No, 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 some yeses, no, some yeses, some no's. All right, cool. Majority knows, majority knows, majority knows. Stop there, stop there. We got the majority of people don't believe that they've been into one. How many of you have ever been into a bar or a party where alcohol is being served legally? That is a safe consumption site, good people. You see where our biases are? You say, I've never been there. Yes, we have. Yes, we have. As a matter of fact, this weekend, some of you are going to go into a bar, safe consumption site that has policies and procedures around what you can and cannot do, what you should and should not do, right? And you're going to go into that space and you're going to consume, hopefully responsibly. There's policies there. There's bartenders that have been trained. There's an age limit in terms of serving, all of those things, right? And so, again, to Sarah's point early on, we need to deal with our judgments and with our biases. And remember that piece on stages of change? Well, dead people don't recover. Dead people don't recover. And some people are in pre-contemplation. And just say no is not a policy. That is an idiotic statement. Just stop is not a policy. It is an idiotic statement that's not based in evidence or science. It's based on stigma and judgment. And so I want people not to die of an opioid overdose. I want people not to get HIV or hepatitis C. I want people to be as healthy as possible so that when they're ready to enter this process that I call recovery, that some people call wellness or getting better, whatever it is that people call it, it's up to them, that they're healthy as possible, right? And so that's why I left the harm reduction piece as it relates to the multiple pathways of recovery. That's why I left that for last, because I knew that there were going to be some discrepancies in that one. Thank you for doing that. So, as it relates to incarceration, we need criminal justice reform. We desperately need this piece here, right? I was watching the news last night. You saw all the fires you've been seeing all the fires in California. Do you know that thousands of the firefighters are people who are incarcerated? Do you know that they're getting paid $1 an hour for fighting those fires? And do you know that many of them, when they get out, they can't be a firefighter because they have a criminal offender record? Jordan, and then refused the job. On point there, Jordan, in the chat, right? So think about it. Right now, how many of us in this room have something that we own that was created by an inmate? Do you think that you own something that was created by an inmate? All of us do. If you have a car, your car has a license plate. If you've never been by the factory that produces the license plates, right? Why? Because they're created in jail. There's a whole bunch of services that are created behind the wall, right? Behind the wall, that those people are being paid pennies on the dollar, and when they get out, they can't get a job in that same field doing the same one. And this is why we need this type of reform. We need not to just be trauma informed, and I hope that all of you are trauma trained. We need to be social justice informed. And this presentation, this conversation that we've been having, is social justice informed, right? Because we're thinking about how these things impact people disproportionately, right? How the Hispanic, Latino, Latin population, and as you can see, this has impacted Native people, Black and African American people disproportionately as well, right? So we need to continue to think about the following. There's no typical Hispanic or Latino client. There is no typical. Much of the descriptions given in here will be very pertinent to some individuals and perhaps not to others or limited others. So be very careful not to paint with a broad brush. Creating equity is the most effective way to engage in people in recovery processes. So how is it that we create equity? And notice that in current historical time, equity has just become a bad word. And there's policies that are being moved in that direction, right? So be very careful. Be very careful as you move forward. But there's some things that we can do to humanize people, to treat people with decency and respect, and to engage people in processes that are designed, once again, to bring people in. This is something that I didn't say in the multiple pathways piece, and I should say it now. What's the takeaway on the multiple pathways piece? What is the takeaway on the multiple pathways piece, right? For me, it is the following. Put a menu of options in front of people. Today is Thursday, the weekend is around the corner. Many of us are going to go into a restaurant. Let's take a page out of that book. And you're saying, what does a restaurant have to do with multiple pathways of recovery? I'm going to use it as an example. When we go into a restaurant, we are offered a seat at a table. We're offered something to drink, and then they bring out this revolutionary thing called a menu. And they ask us, what do we want? They don't say to us, you're having hot dogs whether you like it or not. And so the menu should have the multiple pathways of recovery. And people should be allowed choice, self-determination, and agency. Remember that piece when we defined recovery? Self-determination, agency, and choice. And then people pick off of that menu whatever they want, right? And we get to support them in whatever their journey is. And some people pick one pathway, or they'll pick two pathways or three. So some people will pick going to church, going to a 12-step group, and doing acupuncture. Good for you. And if that worked, great. And if it didn't work, at least you know that it didn't work. Let's try something different. Some people will try church only, a faith-based process. Some people would choose 12 steps. Some people would choose Dharma recovery. Some people would choose celebrate recovery, right? Whatever those things are, they're going to select, and we get to support them. Some people need residential and they want residential. Some people want to do it outpatient, whatever that is. Let us not impose our will on other people. Just because I run a residential treatment facility doesn't mean that everybody needs residential treatment. Just because I work at an outpatient doesn't mean that everybody needs outpatient. And just because I come from a 12-step fellowship doesn't mean that everybody needs 12-step. And just because I come from faith-based doesn't mean that everybody needs God and everybody needs church. We need to move away from those things. It's about choice, respect, strengths. It is about all of that, right? In the few minutes that we have left, I'm paying attention here to what's in the chat, but we're going to come to what's in the Q&A to see how many of these we can answer. And so we have 10 minutes for some discussion here. Let me figure, because this first one is a lot of this is more of a. Let me read this first one out. We are a private not-profit commission by our county. Our email address and office are both county connected. What would be the best way to connect with the underserved Latin population in our region, who are now very much worried about government threats to deportation? Even if a potential client is legal resident, they may be worried. Yep, got it. We feel that that these folks might be avoiding, seeking, or needing services for fear of, right, deportation, discrimination, all of that stuff. Let me thank you for the question, Kimberly. It is a timely question. Many people have been asking this. So some organizations, due to COVID, moved towards providing services that are virtual. That is an option for some organizations who have the capacity and some clients that can engage through smartphones and computers and that sort of thing. That is an option. Another option that has been used by many organizations is that they have people who don't sit in their offices making appointments and waiting for people to come to them. We need to be in the community. And recovery coaches, some people who are even clinicians, visit people in their homes, in the community, in safe places. They meet people in places where people want to meet, as opposed to where we want them to come to. Because we go around saying, oh, we meet people where they're at. And then you need to come to my office. Really? You meet people where they're at? That's not true. So being in the community, virtually providing services, those are our options. In terms of distrust for government institutions, on behalf of people of color, and in this space, I'm talking about Hispanic, Latino, Latino, we have a healthy fear for government institutions. And all of our agencies are viewed as government institutions by many people in the community. So if we know that that distrust is there, what should we do to mitigate that? I think that we need a presence in community. So get your people out to go to community fairs, to cultural events, to sporting events, invite people into the community, serve food, music, develop relationships, not with just the self-appointed leaders within communities, but develop relationships with stakeholders and people who are gatekeepers within communities, your faith leaders, the people from community that people know and trust, because those people will get the word out. And then I'll end with this. Your most important outreach workers within your organizations are not the people on your staff with the title of outreach. It is the people that you serve. If you serve them with decency, with respect, if you incorporate the cultural elements, if you incorporate issues of language and understanding, and if you lead with empathy, those people are going to leave there and talk about you in glowing ways. Yes, this place, as a matter of fact, you need to go there and see Kimberly because she was great and she treated me and she allowed me to get in and all that stuff. And Sarah was great and all of that. But if you're not, they're going to say, don't go there because there's a guy there named Hanet and he's an asshole and you don't want anything to do with him. And that word of mouth gets out a lot more than whatever flyer brochure you have. Right? Now, brochures and flyers, all of that is important, but this is about community relationships. So I hope I did that question some justice. Will we have access to the PowerPoints? The answer to that is yes. Access to the recording, someone else can answer that, but I'm sure this is being recorded. So we answered that one. Hi. Who do we contact if we did not receive a certificate? I'm going to let that up to Samantha and others here to answer that, because those are the most appropriate people. I'm looking for stuff that has to do with content for Latino families specifically. How can we be introduced to alternative paths of recovery, or at least perspectives, without seeming like an enabler? So again, I think you saw what we did here by way of the multiple pathways of recovery. That exercise can be done with different people in different ways to raise awareness, to educate people, because if we say Dharma and recovery, they're going to go, what's that? Again, that's an opportunity for us to engage, to educate, right? But you must put options in front of people that are available in your neighborhoods, in your communities, in the languages that people speak. If not, it does me no good to talk about Dharma recovery if it doesn't exist in the community, right? So I think that we need to engage with families. We need to bring them in as much as possible. And we also need to go to where they congregate, where they're at. We need to go into churches. We need to go into community settings. We need to go and be there with a table, with information, and develop relationships and engage with people and educate the community where they congregate. Many people say, no, they need to come here. Well, if that's the model, it's a deficiency-based model, because not all people are going to come to us, right? What bigger issues do you foresee for treatment access for Hispanic Latino population under this administration? As historically, health equity has not been so, what do you recommend to do? Listen, I'm an advocate, so advocacy is where it's at for me. This is a difficult time, but I'll just say this to you. We have lived through more difficult times. We have experience with difficulty. And so don't let difficulties paralyze us, right? Again, I double down where I have power. Where I have power is I treat people with decency and respect. I engage with people. I bring people in. I go out and find resources. In terms of foundations, in terms of government funding, but also through private funding. I do that work on a daily basis because we're committed to that on the ground, right? And so it's to do more of that. We double down on treating people humanely. We double down on humanizing people. We double down on our recovery efforts. We double down on all of that. There's some things that are going to happen, that are currently happening, that some of us are going like, oh, wow, this is very challenging. But we have to do what we have to do. And again, we've been through some stuff before. There was a point in time where slavery existed. And here we are. There was a point in time where women couldn't vote. And here we are. There was a point in time, right, that there were certain things that were happening that are not happening right now. And here we are. Why here we are? Because we're standing on the shoulders of the people who came before us. Our role is to make a contribution to not become demoralized because of what's happening. How do we build trust and access in the Latina community in the time of increased hateful othering rhetoric towards the Latina community? I think I've mentioned that in many different times. It's about engagement and it's about collaboration. This I haven't mentioned. We cannot, no one organization, no one individual can be all things to all people. We cannot. We cannot be all things to all people. Therefore, we need to collaborate. We need to collaborate with other organizations who are doing really good work. And so when we enter into collaborations, we are stronger, right? And we're called upon to do that. So it is 29 after. I have gotten through all of the questions that are in the chat. I want to give a chance to Samantha to bring us home here. But on behalf of me and the National Hispanic and Latino Behavioral Health Center of Excellence, we want to thank you for your participation, for coming today. I didn't hear any voices out loud, but your voices came loud and clear through the chat. Thank you very much. Muchas gracias. Enjoy the weekend.
Thank you so much, sir. Just again, for the people that maybe came in a few minutes late, there will be a survey for both organizations, APNC, as well as the Hispanic Latino Behavioral Health Center of Excellence. Please complete both of them. It just kind of helps us make sure we are providing you with the best services we can. Also, certificates from APNC for the APNC participants. You will get your completion certificate 24 to 72 hours from now. And then recordings for the event we will share, as well as the slides if you have not already received them. And we sincerely appreciate all of you attending, as well as you, Dr. Hernandez. Thank you so much, and I hope everyone has a great day.